We have next speaker, who is Dr. Aseem Kumar Tiwari. Sir is the director, Department of Transfusion Medicine at Medanta Hospital, Gurgaon. And Sir has more of 130 publication in national and international journals. Sir is also a recipient of H.D. Shorey Award and also J.R. Jolly Award from ISBTI. So Sir is a life member of ISBTI and currently Sir is serving as a vice president of ISTA, and he's also an NABH assessor, and a lot more to add on profiles of Dr. Aseem Kumar. Over to you, sir.
Thank you very much. Good evening to everyone. I would like to thank CAHO, Dr. Gajendra and Dr. Shammi for inviting me. Thank you. I'll be talking about clinical transfusion procedures. The entire topic has been made from this WHO module, educational module on clinical use of blood, which is freely available on WHO site. So the outline is that I'll be talking about principles of clinical transfusion practices, the steps, the decisions to transfuse and the levels of urgency of the patient requirement. How do we identify the patient correctly? How do we request the blood components and how does the request form look like? How do we draw the sample for pre-transfusion compatibility? And how do we do the compatibility testing? What is the correct storage of the blood component? How do we collect blood component from the transfusion services and take it to the bedside of the patient? If we need to store it at bedside, how do we do that? How do we infuse? And what does visual inspection of the unit mean? What are the equipments which are required for transfusion? And what are the checks which are done just prior to the transfusion? How do we administer a blood unit and how do we monitor? And finally, how do we check the effectiveness of the transfusion? So the principle is that we need to give the right blood to the right patient at the right time. And there should be national guidelines. And there has to be a hospital transfusion committee, which continuously monitors the clinical blood use and reviews transfusion reactions. There has to be an initial training and competency assessment of the all staff, and then there has to be a continuous competency also. And we also need to audit the processes to ensure that everything is going the way it is supposed to. Now, there are several steps in the clinical transfusion practice. The first is that we assess the need for the blood. We take the consent of the patient. We determine the urgency of the transfusion. If the blood is needed urgently, then we contact the blood bank by telephone and use the approved method for urgent request. In case of elective, we select the blood component and the quantity required. We use the blood ordering schedule as a guide to transfusion requirement. We'll talk about all these things one by one. We complete the blood request form, which is filled accurately and legibly. We verify the patient identity to ensure that the correct patient has been identified. We obtain and label the sample correctly because there are a lot of instances. If this is not done correctly, then there can be wrong blood in tube called WBIT, which is a major concern world over. We have to send a blood request form and a blood sample. The blood bank performs the pre-transfusion test and select the compatible unit. It has to be transported under certain conditions, and they have to be stored if it is not required immediately. To again check the identity of the patient before transfusion, also identify the identity of the product and do the necessary documentation. Check for pre-medication if they are indicated. Usually they are not. Record the baseline vital signs like blood pressure, respiratory temperature, pulse, to ensure when we monitor the patient, if there is change in the vital signs, we know that the patient is reacting adversely. We administer the blood component, do the documentation, monitor the patient before, during, and after transfusion. And we identify and respond immediately if there is an adverse reaction. And we record any transfusion reaction in the notes and report according to the hospital policy and procedure. So this may sound a little overwhelming, but we'll try and simplify all these steps. This was a very comprehensive list which had all these steps, but we'll simplify the entire thing. So the first thing is, when we assess the need for transfusion, we also assess whether it is emergency, whether it is urgent, whether it is routine, but there is a definite need for blood. And the fourth is that it is routine, and the blood may not be required, blood may be required, may not be required. There's only a possible need for blood. And we'll give you illustration of our own hospital. If it is a life-saving situation, we issue O negative without cross match. It's under 5 minutes that the blood is issued. If there is an urgent need, but we have 15 minutes, then we save on O negative. We give that particular group, we do a quick blood group and do the group specific unit without cross match again, because 15 minutes is not enough for cross matching. But if we have 30 minutes, then we do a immediate spin cross match and issue the blood. And in the fourth situation, where there is only a possible need, we do blood group and antibody screening. So if the blood is required, we can issue it in quick time, but it is not cross match because it is only a possible need. So these are the four different levels of priority or urgency in a patient that is possible. Now, if we have to order blood in elective procedure or a surgery, then of course we, ideally should have sufficient time to allow completion of compatibility test. It's a good policy to have MS-BOSS, called Maximum Surgical Blood Ordering Schedule, which is the expected blood use for each elective surgical procedure. And it reflects the expected use of blood for common procedures. So, for example, hysterectomy or a gallbladder surgery or a bypass surgery, what are the blood that is commonly, what is the number of blood units which are commonly used, and it depends on the complexity of surgery and expected blood loss. The MS-BOSS is developed locally by a hospital transfusion committee, and it is a guide to optimize the blood use and compatibility testing. So you don't keep all the units cross-matched in several procedures where there's the usage is not so common. We just do a group and screen. So we only do the patient blood grouping and antibody screening, and the blood units are ready in the blood bank. Should they be required, they can be given in in a very short turnaround time. Now, it's extremely important. I need not overemphasize that the patient has to be identified correctly. Right at the beginning, if we don't collect the correct blood, then everything which happens thereafter can be incorrect. So it is very important that most of the hospitals would use two identifiers: name of the patient and unique hospital ID, written as UHID here. There can be any unique number. In our hospital, we normally call UHID, unique hospital information identification of the patient. In some hospitals where there is no UHID, then the date of birth along with the name can be two identifiers. Now, once the patient has been identified and the sample is collected, we also need to take a consent, a transfusion consent from the patient. And the transfusion consent discussion, according to the WHO guidelines, have to include information about anticipated benefit of transfusion and the reason for transfusion. So, for example, if there is a surgery and there is an expected loss, then the patient needs to be told that there is expectation that there would be blood loss, and that's the reason why he may be given transfusion. Potential hazards of the transfusion, as well as the potential risk of not receiving transfusion. So we need to tell both that there are certain risks involved, but if you don't take transfusion, then what are the risks which are involved? If there are any alternatives, then those alternatives also need to be discussed with the patient. Then we have to also document the consent, and it has to be a written document, a written consent which is needed. It is not only needed from a quality perspective, it is also needed from a legal perspective, these consents are of very, very important when it comes to somebody challenging the hospital or challenging the healthcare facility in a court of law. Now, a blood request form has to have again unique patient identifier, most commonly name and UHID, unique hospital ID, the time and place at which they are needed, so and so ward and so bed or so and so operation theater, and at what time are they needed today, and at what time, that has to be specified, and what is the type of blood component and the quantity of blood component. So 2 RBCs, for example, are required in OT2, and this is the patient name and this is the unique ID of that patient. So this is and the same information of patient ID has to be also on the sample which accompanies the request form. So it's a very important part of the process that the form has to be filled up correctly and legibly. Sometimes people also use the computerized form or an electronic form, and it has to accompany the sample, which is of course a physical sample, which has to accompany the form, or the even if the entries are electronic, the sample has to arrive to the transfusion services for the compatibility testing. Now, the samples which are taken for blood group and compatibility testing, again, very important. If the patient is conscious, he or she has to identify herself. A lot of hospitals use now a wristband. So a wristband has a barcode and the name of the patient on the wrist, which is a better way to identify the patient. An appropriate sample has to be sent. In our hospital, it's an EDTA sample. Mostly it is an EDTA sample. It has to be clearly labeled at the bedside. And again, 2 identifiers, normally name and hospital ID, has to be used to identify the sample before we collect the sample at the bedside. Now, the compatibility testing which is happening in a hospital includes 2 important parts. One part is the what tests are done in a patient, and the second is what tests are done in a blood unit, and they have to tally with each other. So in the patient, it has to be ABO grouping, RH grouping, antibody screen, and if the antibody screen is positive, then identification of that particular antibody. The compatible unit has to also have the group which is either identical or compatible and the RHD type. And if the antibody is positive, then it also needs to be negative for that corresponding antigen. So for example, it is B positive. But if there is a KEL antibody, then it is B positive KEL negative unit which has to be issued to the patient. Now there are tables like this.
So excuse me.
For example, in this table, there is
5 minutes.
recipient blood group A, B, AB, and O, and correspondingly, what are the red cells which are compatible. So in a A group, A and O is compatible. In a B group, B and O red cell are compatible. And likewise, you have a compatibility table for plasma and platelets, which are used by the transfusion services. Now, group and screen, as I said earlier, is a very common procedure which is adopted by most of the blood banks and the hospitals, where you only do the patient blood group or blood type and antibody screen at the time of admission. So when the patient requires blood, it is very easy to do an immediate spin cross match and issue blood in a very short turnaround time. So the ABO and RHD group is determined and the antibody screen is done. Thankfully, out of 199 are antibody negative. So there's a very small minority of patient which is positive. And you also get time in case a patient is antibody positive to find a corresponding antigen negative blood for that patient when the patient, before the blood is actually required in an operation theater or during the procedure. Normally, the validity of group and screen is 3 days because this is the period when some of the patients can develop new antibodies. So you need a fresh sample and a fresh antibody screening after 3 days. And if a blood is required, it takes hardly 15 to 30 minutes to cross match and issue the blood unit to the patient. It's very important to have the correct storage temperature for each blood component. So red cells are 2 to 6 degree, the platelets are 20 to 24 degree, the plasma is stored at minus 30 or lower temperature. And all these equipment have alarms and graphs showing temperature. They are calibrated against calibrated thermometers, and these components are stored in a manner that allows air circulation so that the temperature is uniform in the entire refrigerator across the shelves.
So may I
Now,
request
when the blood is collected by the
excuse me?
from the transfusion services to be taken to the bedside near a patient, it's very important to tally the details. So there has to be a written documentation with patient identifiers. We call it issue slip at our place. And there is a compatibility label which is stuck on the unit before it is issued to the patient. And this information is entered usually in a issue register before it is issued from the blood center. And again, the name and UHID are the commonest two identifiers which are used to identify the patient correctly. The issue register would also have the time of issue and the ABO group and the compatibility and who has done the compatibility. Certain details have to be documented.
So excuse
Now,
me.
the way it is
Excuse me.
transported, so there are insulated transported boxes which are used to transport it from transfusion services to the bedside. And these boxes are validated in a hospital, it is easier to transport, but if it is being transported from a centralized blood bank to a hospital which is far off, it is all the more important that these boxes are properly functioning and validated. Clinical staff is responsible for ensuring that the blood components issued by the blood bank are kept at correct temperature until transfused. And there are two rules which are followed. The first rule is called a 30-minute rule, which means that the transfusion has to be initiated within 30 minutes of receiving in the ward or OT. And the second rule is a 4-hour rule, which means that the transfusion should be completed within the 4 hours of initiations. So these are two simple rules. If adopted, ensure that blood is correctly initiated and transfused completely. These rules are important. A visual inspection plays a very important
excuse
role.
me. So can you hear me?
Yes.
May I have you to wrap up, please? We are running short of time.
Yes, I'm finishing in
Yes,
next
please.
couple of
Thank you.
minutes.
Thank you.
Visual inspection plays a role, and there are available which shows how a clot or a lipemia can be detected in a bag. The equipment required, there is normally a cannula is required, and there are sizes which are available. So for RBC, it is normally 20 to 22 gauge, which is required. And usually the cannula is changed once in 12 hours. There is a compatibility label, so the details have to be tallied between the label and the patient. And again, name and UHID are the two most important parameters which have to be taken. The administration is that the vital signs like temperature, blood pressure, pulse, respiratory rate, oxygen saturation has to be monitored before the transfusion, and very importantly, immediately after the transfusion in the first 15 minutes. There are certain rates of transfusion. So for example, the RBCs have to be started slowly at 1 ml per kg per hour for the first 15 minutes, and then you can increase to 5 ml per kg per hour. The plasma and platelets can be given at a slightly higher speed of 10 to 20 ml per kg per hour. Monitoring, the patient has to be monitored, especially very carefully during the first 15 minutes. And if you need to see the effectiveness, there are most important parameters. RBC is hemoglobin other than the clinical condition. And the platelets, the bleeding and the platelet count, the FFP, the bleeding and INR, and cryoprecipitate fibrinogen. So these are the common laboratory parameters which have to be monitored to see the effectiveness. Thank you very much.
Thank you so much, sir.